So, episode 1 of Stop the Clock. Stop the Clock. Yeah, getting to grips or getting people to understand exactly what the stigma is behind things like regenerative medicine. One of the biggest issues we've been having is Google, and that is reflective of some of the issues that you have with regenerative medicine today. And I say the term really fast, but do you want to explain a little bit about what regenerative medicine actually is?
So, regenerative medicine is using a patient's own cells or somebody else's cells to try and treat disease. It encompasses quite a broad area. So you can use biomaterials, you can use cells, you can use potentially even gene therapy and things like that come into it, where you can do manipulation of cells. But the ultimate game or goal of regenerative medicine is to try and modify or improve a disease process. And I suppose the holy grail that everybody's seeking is getting rid of a disease. So if you've got abnormal cells or abnormal function, can you actually resolve disease? Because in medicine, we use drugs all the time. But drugs, by and large, will modify the symptoms of a disease. They don't get rid of it. They don't tend to get rid of it, or they're trying to make your body adapt to the disease. For instance, diabetes being one of them. It's a good example. The drugs that you take replace insulin. They don't make your body cells normal. So in a type 1 diabetic and in some forms of type 2 diabetes, the issue is that your body's not producing insulin or enough of it. And what the drugs do is replace it. So you take insulin if you need insulin replacement, or you use drugs that modify the small amounts of insulin your body is producing. They make your cells or your body or the areas in your body that normally insulin acts on, they make them more sensitive. So those drugs means that the small amount of insulin you've got going on or running around the system is its effect is enhanced. But they're not resolving the problem. The fundamental problem is your body can't produce insulin. Your pancreas is shut down, or that the cells in the body are not receiving the signals for insulin properly. The great game changer or promise of regenerative medicine is that you actually you replace the pancreatic cells with stem cells, which can effectively grow new islet cells, generate insulin, and so you replace the insulin loss. So you actually resolve the disease, you get rid of the disease. And that's the great promise of regenerative medicine. We're a long way from being able to do that reliably. We've got animal studies where we've done it successfully. We've got pancreas transplants that have been done. We've got cell therapy or stem cells that have been modified and tuned to produce insulin in mice and rats. And so we've then shown that those animals diabetes resolves. So there's a lot of promise out there, and there's a lot of great research going on all around the world, but we haven't quite got to the end point of regenerative medicine in almost any sphere of medicine. We can't get rid of blindness, but we've got some promising trials showing a reduction in sight loss. We've got some promising trials showing improvement in those with previously permanent sight loss. We've got studies showing some improvement in diabetes. We've got studies showing some improvements in heart function, lung function, but it is still in the relatively experimental stages in many areas of medicine. We haven't got to that great promise where we'd like to be, where we can say, well, we're going to give you a shot of these cells and your diabetes will go away forever. Or we're going to give you a shot of these cells and it may be 3 lots or 10 lots. And your blindness has gone because you've regenerated the cells in your eye that have caused the blindness. And that's the great promise of regenerative medicine. We're still a long way from delivering on that promise. Part of the reason for that is it's very expensive research. So there's a huge amount of cost to this. So the resource required is enormous to drive the research forward. That doesn't mean the research isn't being done. As I said, there's high quality research and there's billions of pounds of research going into this space. However, to get the progress that we really need for the benefit of humans and humankind, it would actually mean that all the scientists and vested interests and commercial companies in the world would work together. But in a capitalist world, we're not getting political here, but in a capitalist world where everyone's out to make as much money as possible, it's just not going to happen, because each company obviously holds its own intellectual property, wants to try and recover. And I understand that if you invest £1 billion in research, you need to make that money back. And so you need to produce something that's going to allow you to make that money back. So, our current system means that people protect research. The collaboration is not that strong. We saw the difference collaboration can make in COVID. We just dealt with a global pandemic, and we saw that the whole world working together has developed a vaccine in record time, 3 to 6 months. They actually had a trial-ready vaccine within 6 months of a pandemic pretty much starting, which is unheard of, because especially in a difficult disease vector like coronavirus, which we have never successfully produced a vaccine against coronavirus. And so whether you sit in the spectrum where you believe the vaccines were successful or not, I believe they were successful overall, because they don't prevent people getting COVID entirely, but what they seem to prevent, if you look at the data carefully, is they prevent severe disease. So those people who get it and have been vaccinated don't tend to get very sick, and that's the big advantage, whereas those who were unprotected and unvaccinated tend to get a more severe form of the disease. And that's what our studies have shown, and that's what the vaccination programs have shown across the world. The disease itself has softened slightly. It now bypasses vaccination, and we know with the Omicron and the more recent variants, you can still get COVID, even though you're triple vaccinated. However, the disease tends to be quite mild.
But sorry, so while you were talking, you mentioned initially with regenerative medicine, I know we got into COVID and, other really interesting topics, but you mentioned 3 types of cells there in relation to diabetes. You mentioned pancreatic cells. There was another one beginning with an A, which was quite a complex one. I can't remember exactly what it was. And stem cells.
Yeah.
That was the third. Do you want to kind of talk a bit about pancreatic cells? If you're a med student, I'm sure people know what it is. But do you want to kind of break that down for the layman in terms of how it works with those 3 types of cells that you mentioned and other similar ones?
I suppose your body has innumerable cells, thousands and thousands of different types of cells that are forming millions or billions of types of functions. It's an incredibly complicated machine, but on a general level, like I said, I don't expect, as you say, sort of from the perspective of a patient, they just need to know my pancreas cells aren't working very well. The cells I think you're alluding to that I mentioned were islet cells. Islet cells are the cells, there's Langerhans cells. There's lots of different cells. The important bit is the islet cells are the ones that tend to produce insulin. There are other cells within the pancreas that produce lots of other enzymes and lots of other things. Pancreas is not just an insulin production machine. It produces lots of hundreds of different types of chemicals and useful useful outputs that your body needs for digestion and lots of other things as well. So it's an incredibly important organ for disease. And I know one of my professors once said to me, he said the pancreas it's like a battery. It has a certain amount of life, and so the more you abuse it, the more you use it. And he's alluding to the fact that we know obesity is a big effector of pancreas function, and we certainly know that for type 2 diabetes, it's almost the single biggest risk factor in those who develop diabetes in relatively early adult age. We know there's teenagers now, due to predominantly obesity, who are being diagnosed as type 2 diabetics in their teens. What is the issue with diabetes? I mean, I think people probably don't really understand why it's such a problem. It's your body not processing sugars in the way that it should do. And those carbohydrates and sugars, this is starting to get a bit deep on the deep side now. Yeah. But yeah, it's your body not having effectively a mechanism by which it can store sugars. Those sugars can actually generate inflammation, damage to cell walls. Like that starts with blood vessels, because that's where the sugars are sitting, in simple terms, and that inflammation, damage to tiny blood vessels, little capillaries. Remember, everything in your body requires oxygen and blood supply. That's every cell. That's every end organ, as we call it. So that's your skin, that's your eyes, that's your kidneys, that's your fingers and toes. All the nerves operate because they have a blood supply. If you start to damage that blood supply at the microscopic level by this inflammatory effect that you have on the tiny micro blood vessels, then all of those areas get damaged. Your kidneys get damaged, your eyes get damaged, your nerves get damaged, and that's why people with diabetes get peripheral neuropathy. They get eye changes, eye disease, which is why diabetics are screened annually for eye disease, because it's sometimes an early sign that diabetes is not under control. And so it's a disease that affects every part of your body. It generates inflammation and damage to that microcirculation, and that microcirculation supplies blood to allows healing and repair, and supplies normal nutrition to every part of your body. So it's really, really vital that if you're unfortunate enough to be diabetic, you take it seriously and you optimize your blood sugar control. If you can get your blood sugar control to normal levels, then actually, by and large, your life expectancy is not very different from somebody who doesn't have diabetes. But that's a challenge. That's a huge challenge. It requires weight loss, lifestyle modifications, because of all the risks you are at with disease, and you need to try and maintain a healthy weight, a healthy diet, watch what you eat. So all of the challenges that come with that are difficult for people. They are difficult, and your overall life expectancy as a diabetic, as a result, is lower. People do die younger if they develop diabetes, and they live a shorter, healthy lifespan. Because in the real world, in medicine, you can live to 100, but if you're sick from 60, and the last 40 years of your lifespan is actually as an ill person, it's not a great way to live. So healthy lifespan years is what's important to people. And so if you want to, most people would agree that they'd rather live to 80 and have 79 of those years healthy than live to 100 or 120 and have the last 40 years with disease and disability or in pain, for instance. This is something that's reasonably well understood. There's a stark fact in that 80% of your life's healthcare expenditure is consumed in your last 2 years of life. So 80%. So yeah, that's a fairly stark figure, and it's something that I heard at a conference I was at a few years ago, and it brought home why everyone talks when we talk about the NHS being a victim of its own success. When the NHS came into creation, the average life expectancy in the UK was sub 60 years. It's now 60, was that 60? Yes, 60. It was under 60 years, and we've now, with 70 plus years of NHS care, have developed a country that now the average life expectancy of somebody born 10 years ago is in the 80s. So that's 20 years gained in 70 years. So that's quite an incredible achievement.
Because one thing you definitely see when you leave the UK is how much we take public healthcare for granted. Because in other countries, I know America is probably the biggest one, the biggest offender. It's crazy. But I mean, how much of, because with the stuff going on with the NHS now politically, what is the effect? You're quite involved with the NHS especially at the QE.
Yes. So, it's a really good question. The NHS is a huge challenge. My preference would be that it wasn't a political tool. It should be separated from politics, and there should be a 10, 20-year plan for the NHS. We sort of know, all the clinicians, the public health doctors, and all those experts out there can plot, and they've been training for 30, 40 years. We've got 70 years worth of experience in the NHS, so we actually know probably what our biggest burdens are, where our disease trajectories are, where we're going to end up in 5, 10, 20 years as a population. In fact, there's already data out there showing where we expect to be as a population in 2030, 2040. So all of that is known. So why is the NHS not planning for 2030 and 2040?
What do you mean?
Well, it's not, because the reason is it's a political device, which means that each government that comes in plans for. They come into power, they look at the NHS, they play around with it a little bit, kick it around the field, and then decide that this is our plan. They try and deliver that plan in the 2-3 year election cycle, and then usually 1 or 2 years before the next general election, they're now thinking about the election and not necessarily the NHS anymore. Then the next party may come in, or government changes, or you get a new prime minister, and suddenly the focus changes again, and they go around and try and reinvent the wheel again. We've seen it time and time again. It's what people often describe as arranging deck chairs on the Titanic, the boat sinking.
Yeah.
And people have forgotten the boat sinking. What they're trying to do is organise the chairs on the boat. Who sits where and where the best view is,
so
when the boat's sinking.
Is it as bad as people make it out to be with the NHS? Like, it's actually failing, it's collapsing. I know there's been a lot of cuts and people are suffering in the NHS quite
well. My view on the NHS is, I suppose, really as a frontline clinician. And so what I can't say is I'm not an expert in NHS economics or NHS finance. Its affordability and its long-term viability is not. I'm not an expert. I couldn't scope that. But what I know is that what I've seen in the last 20, 25 years I've been in the NHS, there's been a huge change. We are getting better and better and better at delivering healthcare, but it's becoming increasingly more expensive. Healthcare in the UK has become predominantly a deliverer of healthcare to the elderly.
Yeah.
Because they are our biggest customer base.
Yeah.
The way we deliver that and make sure people are healthy, it's the oldest part of medicine, isn't it? Prevention is better than cure.
Yeah.
And a lot of people have been saying for decades now, why are we not focused on stopping people getting sick?
Yeah.
Rather than inventing great drugs or treatments for when they become sick. That has to happen, because without that, the NHS is going to sink. It's a boat that can't, unless we start giving up on funding the military, social care, or whatever else, that the other burdens to society. As a society, we either pay more taxes and we carry on funding the NHS. If everyone in the country was happy to pay another 5% in tax, and all of that was protected and delivered to the NHS, they could have the NHS they wanted.
Yeah.
They could have no wait times. They could have thousands more doctors, or tens of thousands more doctors. They could have scans done within a week.
Yeah.
They could have their cancer treatments within 2 weeks. They could, etc., etc. So all those sort of things that we often say happen in the private sector don't happen in the NHS. They could have that, but they've got to pay for it. It's not for free. And healthcare is expensive. And as a society, we have to philosophically look at this and decide what our priorities are.
Yeah.
In the US, obviously, they've made a clear decision. Healthcare in the US can be amazing, but my understanding is 30 to 40% of their population is uninsured, which means that they have very little access to any advanced healthcare. In an emergency, they can get a certain level of care, but the rest of the country just has to fend for themselves. So it's where we were pre-NHS, where, when Anara Bevan set up the NHS, he said, I want to bring a light into the dark of the houses. Because people would, if you couldn't afford healthcare, you killed up in the dark and you died in your house.
Yeah.
And that was it. There was no hope. It was hopeless. So to bring light into those dark corners of people's houses where they knew they could get access to a doctor, specialist care. And I completely accept that the NHS sometimes appears not fit for purpose. There's an interesting story I had of a medical student who was an international medical student, and he actually arrived from Syria. And most of us don't equate Syria's health economy. Yeah. Certainly now, obviously post-war, but I'm talking about pre-war. Oh, okay. So pre-war pre-war before all of the disaster that happened in Syria, and the civil war. It was a private sector economy, but relatively affordable. And what he told me was he developed gallstones while he was over here studying for university.
Was that gallstones?
Gallstones, yeah. So he developed gallstones, and he was having abdominal pain, which is well known.
Is that like
it's
a common disease? To kidney stones, or?
Well, it's not kidney stones, but it's a similar disease. You end up with little stones that produce in your gallbladder. Your gallbladder is a little organ that sits when you digest food. It stores enzymes. Yeah, it's sort of attached under your liver, and it has a little tube that delivers specialized acids into your gut. And so, particularly with fatty meals, if you eat a meal, those acids are delivered through the bile duct from the gallbladder into your bowel, and they help break down those fatty acids and the fatty food you've eaten. So they help with processing in normal diet. But if you develop stones, those stones, if they're sitting in the gallbladder, are often quiet and don't cause a problem. But if one of them breaks or a small bit gets into the tube supplying the gallbladder, they can block it, and that causes quite excruciating pain, which is well recognised. It's called colic. It's colic, yeah. So it's a pain that's because the tube is a small muscular tube and it's blocked. It spasms to get rid of the blockage, and that spasm can be extremely painful, causes vomiting, distress, severe pain. If it manages to pass the stone, the pain disappears. Yeah. So so it's, in most people, it's thankfully a fairly transient thing. They can have minutes, hours, occasionally days of pain, but then it goes away. Yeah. And there's a relatively simple treatment in either breaking down the stones or taking out the gallbladder, what we call a cholecystectomy. That's usually done through keyhole surgery, often as a day case operation now. People are home within 24 hours. That's available, and it's established when we do it and who we need to do it for. And in the NHS, that journey can be extremely painful currently. So literally, so you get the abdominal pain, you go to A&E, and this is what this chap experienced. So he went to A&E. They told him, "We think you've got gallstones." They did some blood tests on him, gave him some strong painkillers. His pain settled, sent him home. Go to your GP, get a referral to the hospital if it keeps happening. So he did that. He came back again, and he went back to A&E again because he couldn't get into his GP as an emergency overnight. So the long and short of it is he bounced in and out of A&E about 6 times in 6 months, so almost a monthly visit. He during that time was still not seeing a specialist because he'd been referred by his GP, but it took him 6 months to get into a clinic. Yeah. When he then saw the specialist, he was then sent for a scan. The scan happened 6 weeks later. He then waited 6 weeks to come back and see the specialist. So he's now 9 months down the line, has been to A&E many more times. So use that resource of
experiencing pain.
Experiencing pain on and off regularly during that period. Has been to A&E now multiple times when he didn't need to have done. It's taken him 9 months to reach a diagnosis, and he's now waiting to see a specialist. Specialist at 9 months puts him on a waiting list. That waiting list currently is over a year. So he will carry on for a year now, suffering with recurrent pain, requiring painkillers, bouncing in and out of A&E. There's a small proportion of the patients with gallstone trouble that actually get into real trouble, as in they get medically sick, because if the stone blocks entirely the duct, then that can cause those bile salts to build up in the body, and they can actually make you unwell. They cause different diseases. Patients become yellow, sometimes what we call jaundice, and that could be related to that. And sometimes the inflammation and the blockage causes an infection, and that infection can be life-threatening. So all of these problems can be avoided. And the pathway in Syria, his father had also had gallstones. And he said, when my father had gallstones, he went to the hospital. They said, "I think you've got gallstones." They treated him. He was then seen by a general surgeon on call, who booked him in for a scan on the same day. He had the scan that same day. So this is now a 24-hour visit now where he's seen an A&E doctor. He's had his pain sorted. He's seen a general surgeon. He's had the scan on the same day because it's all private healthcare. The next day he comes back following the scan result to speak to the general surgeon. The general surgeon says, yes, you've got lots of gallstones, and one of them appears to be a bit stuck in the bile duct. We can watch and wait, or we can put you on a list for an operation. He decides to watch and wait. He doesn't rush to an operation, so he gives it a few weeks, and then in the next month he has 2 further attacks. He thinks, I don't want to live with this, so he calls up the general surgeon and says, that operating list, can I go on it now, please? And the surgeon says, that's fine, I'll see you in 2 weeks, gives him a date. And 6 weeks later, his gallbladder is out, and his gallstones and his problems and all his healthcare problems have gone from that issue 6 weeks later. And that was a process, he says, so that was all dealt with. That was with his dad thinking about it for a month.
Yeah.
In 6 weeks, the whole process was finished. And he said, I've now been in the NHS system for 2 years.
2 years?
2 years.
Still waiting?
So you're still waiting.
Right.
It took me 9 months to reach a diagnosis and see a specialist, etc., etc. So he just said, this is... I don't believe, his view was, he said, I don't even believe this is a first world economy and operates at an advanced level. Yes, I appreciate that we can do quite advanced things, but if this is what we call healthcare, it's broken. And hearing that perspective from somebody who comes from what we would call a developing country, like Syria's got a huge history and has been a hugely advanced and highly educated country for a very long time. But to hear that from somebody from Syria, which we wouldn't equate as having...
First world country. That first world problem is what you can hear, right?
Yeah, so we wouldn't equate as having, healthcare, advanced healthcare. But that's the process, because a lot of the disease we deal with is not advanced. It's simple disease. Common things are common. And the common diseases are probably what create our biggest burdens. It's not the rare things. It's the common things that create the biggest problems and the biggest burden, the biggest backlog and the biggest cost. So if we can get those right and improve our systems and processes and efficiencies, we're on a winner. But if we can't get that right, then we're on a sinking ship.
With the NHS, is it? I know private medical care, especially with places in the US, especially in a field like regenerative medicine, stem cells, etc., there's been a large stigma created in the US of negative, people just wanting your money, giving you anything. And it's quite a medieval concept. However, in the UK, some of the things you just listed, with the Syrian student, med student, his father, there's probably 1 million people who are going to listen to this podcast and say the same thing. Oh, I'm experiencing that right now, and I've got a 2-year wait if they're in the UK or in other countries. With medical care in the UK, where does private healthcare kind of stand right now? Like, where is it?
Well, private healthcare currently, with the large waiting lists and the inefficiencies in the NHS in its recovery from the pandemic, is booming.
Yeah.
Is booming. So people are, at the end of the day, what's more important than your health?
Yeah.
So people are, taking out loans if they can't afford it, or those who have got enough money are thinking, well, that £5,000 or that £10,000 for that operation to get my quality of life back, rather than waiting 2 years, I'm gonna spend it.
Is that sometimes how much a surgery can cost?
Oh, that's an average sort of cost. Yeah.
Really?
So it can be much more than that. It depends what operation you're talking about. But £5,000 to £10,000 is not unusual figures at all for private surgery.
And this would essentially come out of a taxpayer's money with public healthcare, with the NHS. That it's the same cost, but we're paying it through tax. I know.
No, the NHS is actually more efficient. It's a volume-based system, so obviously the doctors are on salaries; they don't get paid per procedure.
Oh, so you're
the healthcare. So when you're paying for a private healthcare system, you're paying for the total pathway yourself, whereas the NHS and the individual doctor's fees and so on is all built in. Whereas in the NHS you got the advantage of volume procurement, and doctors are on fixed salaries, so the doctors don't get paid anymore if they do 1 operation or 10 operations in the NHS. So there's no it's cheaper. So the NHS is known to be an efficient system economically. It's, I would argue, not an efficient system for delivering healthcare. Yeah. But that's a different argument.
Right. So, you offer private healthcare, right? You
work
in the NHS.
Well, you mentioned regenerative medicine. It's a good question. So in the US, stem cell clinics abounded. So I think when 15 years ago, when regenerative medicine or stem cells were suddenly made available to the public, everybody.
What are these stem cells? Like, what are they?
So stem cells are cells in your body that your body generates. I mean, the mother of all stem cells, the omnipotent stem cell, is the egg that fertilizes and produces babies. Yeah, and produces babies. So sperm attaches to that egg, the ovum, and it generates a baby entirely from that single cell. It generates eyes, hands, feet, organs, brain. So it's incredible. Yeah. It's an omnipotent stem cell. It's a cell that can create any tissue from scratch, and it can differentiate and change its. So differentiation is what we call changing your ability to make different cells. It can change. It changes and produces whatever cells are required in a programmed way. Obviously, there's a DNA control mechanism within bodies, and so it produces what it's supposed to produce. So that's the sort of incredible omnipotent stem cell. What the kind of stem cells we're talking about usually, I mean, there are different variations of stem cells, but stem cells, what most people call stem cells, are those fundamental stem cells that have the ability to create new cells. And some of them have what we call pluripotency, and that means they can create more than one cell type. So they can change. And for instance, a bone cell can be made to create cartilage as well as bone. It doesn't just create bone. So it's that kind of interesting research that people are really interested in. But I think there's always a commercial element to medicine, particularly in private sector economies. And in the US, when stem cells came about, the understanding of how to treat disease wasn't there. The quality control of the cells and the cell therapies and what was being delivered to patients wasn't there. Yet hundreds, if not thousands, of clinics suddenly opened saying, we can offer you stem cells. And I think the biggest issue wasn't that cells were being offered, because you could argue patients, as long as they're fully informed, they've got a choice, especially in a private sector economy, because they can say, well, I choose to try the stem cell because I don't want to take drugs. I understand the doctor has told me that it may not work.
Where would they get these stem cells from?
Well, it varies. So sources of stem cells are either yourself, so we can harvest them from you. So common places are from bone marrow, as I've already mentioned, from blood, from fat. Your fat is a rich source of stem cells as well, particularly the tiny little blood vessels that sit between the fat cells. So that's well established, and there are lots of other sources actually, but those are the commonest areas that we harvest the stem cells from, and those are what we call autologous. So that means they come from you, so they're your own cells. The advantage of that is that you're not going to react to those cells; they're your own cells, so you're not going to have a foreign body reaction. You're not going to have a immune reaction to those, because your body will recognize them as your own cells. It's not going to attack them.
Because you can have quite a bad reaction if your body recognizes something as foreign. It treats it like a disease, right?
That's right. It can attack it, and as part of that attack process, it can make you very unwell. So that was always a concern, but we've been using our stem cells in medicine for in excess of 20 years. So we've learned how to minimize that. And there are ways of cleaning and receiving allogenic cells. So these are now cells from other people or from another source, so outside of your source, outside of your own body, fairly safely. And that's already established as well. So we know that we can produce cells that are not your own and use them as stem cells.
Which sounds pretty straightforward, right? I mean, I know there's probably a very complex way of doing it, but where would these American clinics be getting these from? These dodgy clinics who've given stem cells.
So I think it's a good question. So a lot of them were commercialized. So companies produce these cells. Companies produce these cells, and what they can do is, at a very simple level, they can take stem cells from lots of sources, the commonest one being umbilical cord or amniotic or embryonic material. So that's from babies. So it's a waste product of when a baby's born.
Also, it's
They can take the
what gets
placenta,
the
they can take the
yeah.
placenta, they can take the fluid, the amnion, they can take the umbilical cord, which is a really rich source of those stem cells. And those cells do have potential pluripotency, that ability to make different cell types. They can take those cells and they can process them, clean them. They can expand them, which means they make more cells from those cells, or they can just deliver them as they are in a more raw form, in a processed way, cleaned and delivered to the patient.
Yeah.
Those can be living cells, or they can be dead cells. We don't, and none of that has been particularly well studied, and that's sort of the issue. The issue is that you can take cells, you can freeze dry them, so that actually there's no active living components. There's nothing. One of the intelligent things a stem cell has the ability to do is it can drop into a diseased environment, and it reads that environment, and it uses its brain, the nucleus, or so the brain of the cell, to send an appropriate response. Yeah. Whereas obviously if it's a dead cell, it doesn't do that.
Yeah.
It doesn't have the ability to do that. It just has the products, the packets it carries may still be there and may still deliver a signal, but it's not a controlled or a tuned or a programmed signal. It's just a signal. And sometimes that signal may be enough for certain diseases, and for others it's not. And so we don't really know the answer to that yet, is the reality. We're learning more and more every year. We're learning more and more month by month. There are new publications almost every single day in this space. So we are learning more and more, but we don't have an endpoint answer. If any individual comes to me and says, "Doctor, tell me how many stem cells I need to treat my problem," whatever that problem is, arthritis or my eye problem or my ear problem, the simple answer is neither I or anybody else in the world currently can tell them, "Fine, I know this is what you need."
Yeah.
We don't know that. It's a speculative treatment to some extent. It's experimental. We're at the front of the curve in offering some of these treatments.
Yeah.
But I think if you don't offer false promise, if you collect data on your patients and you're open with your patients, the patients can then choose an appropriate treatment. I think patients should have a choice.
Yeah.
And I think I always start off with my consultations of what do you know about stem cells, and what do you think you want? What's the goal of you attending the clinic? And the patient's usually quite clear. They're usually actually fairly articulate, well-educated people that I see, and they've done lots of research, so they usually arrive with some understanding. But a lot of it can be incorrect. Their understanding can be incorrect. As a sort of researcher in this area and somebody who's been educating in this area for a number of years, that's the first thing I correct. So I then say to them, well, this idea that you have of stem cells is incorrect. For instance, a lot of people will arrive with arthritis saying, well, I've got no cartilage in my knee. Can you put stem cells in there and they'll regrow the cartilage? And I say to them, well, no. We've got no evidence that happens. And we don't have those cells currently that are going to regrow your cartilage.
Or is it just...
It is possible. We've done it in laboratories. We've done it with lots of other devices and machines. So we know we can regenerate cartilage, but we can't do it reliably.
Yeah.
And we can't tell, as I said, that individual patient that Mr. Smith, this is how many cells we're going to give you, and this is how many treatments you need, and this is what we can achieve with it. That is unpredictable.
Yeah.
And at the moment, regrowing cartilage for arthritis can be done, but it's unreliable. We can't predict that, and we wouldn't be able to say to somebody that, and we never promise regeneration. The way the cells we've now work predominantly is to generate signals that reduce inflammation, and that inflammation reduces pain. And if you can turn a hot, what we call a catabolic or a hot inflamed joint into a more quiet, less inflamed joint, there may be an element where the switch over from progressing the arthritis and making it worse over time slows down. So I think we are at a stage where we can probably say we can reduce the pain, we can reduce the inflammation, we can probably slow down the progress of the disease. In arthritis, in osteoarthritis specifically, I'm talking about, we can slow down the disease, and there's fairly good data now showing that some of the biologics we use do that. but we can't conclusively say that's going to happen in every patient.
Yeah.
And hence you can't be offering that to your patient.
Yeah.
And I think if they understand that, I think the US issue that you mentioned was people described as fraudulent clinics. One, because they were probably offering stem cells that weren't quite stem cells.
Yeah.
There are a lot of people who call or confound PRP, which is platelet-rich plasma, into a stem cell product, because it does generate some increase in your concentration of stem cells with the preparation of the PRP, but it's very, very low level numbers, not high enough to ever quantify itself or call itself a stem cell treatment.
Yeah.
And PRP can also increase your native stem cell responses. So for that reason, people have conflated that and said, well, it's a stem cell treatment, and that's one of the reasons. So sometimes they were using products that were not stem cell products anyway. Secondly, they were overpromising. So I've seen these sites myself over the years that say we can treat everything. Yeah. We will give you an infusion or an injection of stem cells, and your Alzheimer's will go away, and your eyesight will get better, your muscle power will get better, your neurological disease will go away, your MS will go away. We can help you with anything. And that's just not good medicine, and it's not true, and they've got no proof of that. And that's what caused the problem. That's what caused the problem. That's what caused the regulators of the US to clamp down. That's what caused Google to ban advertising around stem cells, which they incorrectly included PRP in, which is not a stem cell treatment, but because I think many people were claiming it was. Yeah. Which is why Google then took the step of saying, well, we're not. They banded it into the stem cell market and cancelled advertising in that space, which has made it difficult for legitimate businesses that use PRP responsibly. Yeah. I teach and educate on PRP, and I've spoken at conferences, and I've shown people our data. And what we know, we're learning more all the time. And I say that to our patients. I tell them quite clearly that this is what we know now. In probably a year's time, you'll be getting a different treatment. As we learn, we'll change what we give people. I've changed my PRP protocols 4 or 5 times in the last 10 years. So every year or two, I'm changing what we do because we're learning. We're learning that there are different doses, different types of plasma that we're interested in, different components of the plasma that we're interested in. But a lot of it is innovative. It is front of the curve medicine. But we're getting some fantastic results, but I think as long as the patient is clear, and I've told them all of this, they should have a choice. Because I do surgeries. I don't offer patients a guarantee when I do an operation that I'm going to get rid of all of their problems.
We'll just ignore that.
Yeah, that would be irresponsible, and in the same way, as long as there's an open, honest conversation around the treatment available to them and what the outcome of that treatment may be based on our own data as well as published data, I think you can have an honest conversation in this space. I do not... there are a lot of people who just think regenerative medicine shouldn't even be offered to patients, and because it's so speculative and it's so new and it's so experimental. Yet those same people are quite happy to offer operations or drugs which are not proven, and sometimes even if they are proven, are not proven to give long-term benefit to that patient, and are potentially more risky for that patient. So I completely hear that it has to be done responsibly, and it has to be done with honest and patient involvement and consultation. That I can understand, but I don't buy the argument of people saying, well, it shouldn't be on offer at all to patients, when some patients it helps enormously, and for others it saves them or delays operations that they would otherwise not want at this stage, and often it's safer and more cost effective than many of the traditional treatments that we have available, like steroids, which is an alternative. So the arguments are multiple. And I accept that regenerative medicine is done irresponsibly in many places. But we pride ourselves on not being one of those irresponsible places. And we are, and the more speculative or newer treatment is, the more direct and honest we are with our patient. And we tell them, this is a new evolution of a plasma treatment. it has come out in the last year. This is what we think it does better, and we'll be following you up to see if that is the case. And as long as you understand all of this, these are the risks and benefits, and that clear discussion generates an outcome where the patient chooses.
And what I'm trying to do is pick up, because there's a lot of what you're saying, which the public is not aware of, and it's a lot of the stigmas that the public currently have. Especially, I mean, it'd be great to have someone from Google sat here where I'm sat and ask you questions like, okay, we banned and we have a negative kind of.
You're not going to get someone from Google, are we? Do you think?
If we could, but there's a lot.
Because the people who make those decisions are probably high up. Whereas
they just don't want to deal with the headache of giving their platform a negative name. Because I know with Google, what they do is research and publications. If you want to do advertising on that, which is quite, I don't know the term to use, but I guess sensible of them to allow people to access, research and learn more. However, there's a lot of people. I mean, you had Jake Hadley here recently, who's, some people know him, some people don't. He's a UFC athlete and a friend, training partner. And he had Goldic recently to repair something that would have taken him otherwise a very, very long time. And there's an example of him. I think the most famous example, I mean, you can correct me if I'm wrong, is Eddie Hall. He's had PRP done by one of your colleagues, Dr. Suresh.
That's right. So, I mean, I think we know in elite sport, there's a concept that people talk about of marginal gains. Marginal gains, meaning that if you do everything, so what produces a professional athlete's outcome? So what's the difference between the person who's number one and number two? We know that old saying that nobody remembers who came second, right? So everyone remembers who came. So what is the difference? The difference we know sometimes is 1 second, or 0.1 second, or 1 point on the board, or one goal, etc. One extra punch that gets you that extra point in a boxing match or a UFC competition. That means you win, rather than the other person wins. So the margins can be very, very small. So in elite sport, it's not a new concept. We've been talking about it for decades. Whereas what you do is you make your clothing a little bit better. You make your gloves a little bit better. You make your training and strength conditioning a little bit better. You make your nutrition a little bit better. You make your rest a little bit better. You make your sleep a little bit better. You make your bike a little bit faster. You make your wheel a little bit thinner. You make your aerodynamics a little bit better. You shave your legs in a certain way, etc. So all of these things give you not a 1 or 2% gain or a 5% or a 10% gain individually. They're almost immeasurable. The gain they give you is immeasurable. You can't say that they'll even give you 1% improvement. What you've noticed is that each one may give you 0.5%. And then you've done 10 different things. And cumulatively, they give you that 2-3% or 5% advantage or 10% advantage over your competition. And that's marginal gains. Each thing that you do gives you that extra 1% or 2% or 5%. Accumulating into what you need as a professional athlete to be on the number one spot instead of the number two spot.
And the higher up you go in that pyramid of skill, the more those marginal gains make a massive difference.
It makes a difference, and so that's the concept that we understand pretty well in elite sport. So when I get an athlete in as a professional athlete, they want recovery. They want to be at the peak of their performance. They want to recover quicker, not lose muscle mass, training time, agility, proprioception, all those things. They want to get back to training as quickly as possible. And we know all the gains from that. So if there's something that we can do that potentially gets them back at the elite level 1 week earlier, 2 weeks earlier, that can be a massive difference. That can be that 2% gain before their next fight or their next game or their next competition. So I mean, the breadth of our treatments are quite broad. We've had Jake in, as you said, who's a UFC athlete. We've had we've had tennis players. I've had we've had a golfer in, etc. So we treat them from all backgrounds. But they come to us because they want that extra few percent. We don't promise them that that's what we can deliver. We're always honest. But we tell them what we know. What we know is that certain treatments that we have generate less scar tissue and generate more normal tissue. And for a weekend warrior like me, who plays tennis with the kids on a weekend, I probably wouldn't notice. I wouldn't notice if my muscle tear or my tendon tear was 2% better. But a professional athlete who lives at that peak performance stage where they are 1% slower or their tissues are 2% weaker, potentially, when they're at that sort of level, they may notice. They may notice, and as long as we're honest with them and we explain that we can't guarantee a result, we do not know if this is going to happen. We don't know if they're going to recover quicker. But there's data to suggest they may, and I think ultimately they take their choice. So if they think, well, actually, I know I want to try that, and certainly in a lot of these athletes' cases, they get referred to me for a particular treatment. Sometimes I modify that treatment. I may use something else on them, but. Jake in particular was referred to me for a stem cell treatment. So that decision had already been made by the head of medical at the UFC. They said he's injured. In the US, we would treat him with this product, and this is a stem cell product. I want him to have that. That product's not licensed in the UK.
What was the product?
We won't name it because it's... Well, no, it's not confidential. It's you're name dropping products, and I don't think that matters. There's lots of different ones out there. That product isn't licensed in the UK, and there's controversy around it anyway. Again, as a researcher in this space, my response to the head of medical there was, we use proper stem cells, not this product. and that was slightly tongue in cheek. I was no, but I was just saying to him that we prefer other products here, and plus this product isn't licensed for UK use. And so I gave him all the alternatives. I then discussed the pros and cons of the treatment regime, including costs, etc., with both the medical team and the athlete. And then we made a treatment plan together, all in agreement. Everybody understood the limitations of what we had. Informed consent was taken, and then we proceeded to treat. And we chose Goldig in this case because it's a very clean acellular treatment. It's not involving stem cells actually. What it does is it enhances your native stem cell responses to create a healing response. And what we've shown both in animal and human studies is that you see more normal tissue. So it reduces inflammation, and where tendons, when they're healing, or ligaments would sometimes generate scar tissue, they generate less scar tissue and more normal tendon cells and more normal ligament cells and more normal muscular cells with this product than otherwise. So that's what we used. And certainly, I mean, again, once I'm a scientist, I don't claim that one case makes a case. It's a case study, but it's not science. It doesn't mean I can say, well, because this athlete's done incredibly well, that's what everybody should be having with this injury. Because there are many patients it will make no difference to their overall outcome. But in his particular case, he seems to have done very well. So he's got back to training. I've had a message from his rehab team, and he's already back in strength and conditioning. He's already, doing some strength build-up and proprioception and lateral training, which I didn't think he'd be at this stage, at this early stage. So he's doing very well, and I'm hopeful that obviously he'll get back into the ring in the coming months, fighting fit. But again, we'll follow him up and we'll see. A lot of people say to me, including that particular athlete, has already asked me, "Are you going to scan my knee to see if it heals?" And I said, "Well, the simple answer to that is we'd love to. We'd love to scan lots of patients, but obviously there's a cost to a scan. And in everything in medicine, there's a risk benefit. And if people are paying for scans that they don't need, Because if you've got no symptoms and you're back at peak performance, why do you need a scan?
Yeah.
It's an academic scan. It's for interest. And so, I for research purposes, yes, we do scans on people. So when we're running studies, that's built into the protocol of the study. But routinely, I don't rescan patients.
Yeah.
We have got an idea where we've set up a Pinnacle Foundation, and a percentage of the income that our clinics and clinicians earn will be delivered to our research and development department, the R&D department. And for certain studies, we will be doing samples, biopsies, fluid analysis, blood tests, and scans. But we will pay for that.
Yeah.
So if it's part of one of our research trials, we'll pay for that, so the patient's not being asked to pay for a scan. Usually MRI scans, we're not using radiation, and around 30 years of MRI data has shown that generally they're very safe scans. So we're not really harming the patient anyway. And a lot of our patients are actually interested to know whether things have improved.
Yeah.
But that's a plan for the plans that we've got ongoing, studies that are ongoing, and research projects for the future.
Wicked. So, I mean, with Jake, we'll get into the Pinnacle Foundation in a second, but just so people are aware, the alternative to what he was given in terms of this treatment that you just mentioned that you gave to him, the alternative would have been an actual invasive surgery where they open up the knee and have to physically repair it.
Well, no, not necessarily. I mean, when we're talking about ligament injuries, we tend to, in his particular case, it's a collateral ligament injury. We talk about. I think we need to be cautious about mentioning Jake, don't we?
Should be fine. It's organic anyway. I don't think he'll mind to get free publicity.
Yeah, we just need to be careful, because we need to check his permission before we actually finalise that. Say if we mention you on a podcast, just call him athlete. Yeah. So in this particular athlete who had a collateral ligament injury of the knee, we grade ligament injuries in grade 1, 2, 3 broadly. Yeah. And what that actually means in visual terms is a grade 1 is where the ligament rips a little bit and some of the fibers get disrupted, but actually its length and most of its strength is still maintained. Right. Level 2 is where you lose a bit more of the fibers and you can sometimes get a bit of laxity. So it's not quite as strong as it was. And grade 3 is where you lose integrity, so it tears completely, like complete tear. The 3s usually need surgery. Some of the higher grade 2s, because you can imagine now when I've said 1, 2, 3, that's a very simplistic way of saying there's going to be 1.5s, and there's going to be 2.5s, and there's going to be 2.8s, and there's going to be 1.5s, 1.45s. So not everyone's injury is going to be slightly different. Yeah. We can't quantify that, so we tend to just leave a simple classification or grading. And what that does is it gives us the best gradings give us a treatment plan. And a grade 1 generally just needs some rest, some exercise to keep their strength up, and they can go back in training quite quickly. Yeah. Sometimes with a bit of support like a brace. Mm-hmm. A grade 2 usually needs a higher level of protection, either a brace or a splint. They can start to do inline work quite quickly to try and maintain their strength. But there's a danger they can convert to a 3 if they're doing contact sports. Yeah. Or somebody hits them, any uncontrolled manoeuvre, a fall, another hit. So they usually need protecting for a fair bit longer. So that can be 3 months. Yeah. Not unusual to have 3 months off contact sports or training, sometimes even as much as 6 months, depending on what kind of sport you do. And if you're in the 2 to 3 category, 3 usually needs surgery, especially at the elite level. But if you're between 2 and 3, and in this particular athlete's case, he was like a 2+. Right. And he had a little bit of laxity. You could feel that his knee was slightly lax and opening up on that side where the ligament was torn. And that's what the MRI showed. He had an MRI scan which proved that. And that would normally be 6 months. That would probably be 6 months out of competitive contact sport. Right, yeah.
Where he's just resting, there's no treatments or anything, he's just kind of taking it
easy. So that would be the normal, and just rehab physio, a period in a brace maybe to protect, so the ligament doesn't lengthen, because if it heals long, you end up with laxity long term, so you want to try and protect him in a certain position. And so what we've tried to achieve is more natural healing, and possibly, but although I'm not guaranteeing that, I didn't guarantee that to the athlete, is an accelerated healing. And what that may mean is that you can possibly rehabilitate that a little bit sooner. And what it may mean is also that when he reaches the end point of rehabilitation, his peak performance is that 1% or 2% better, which is very, very difficult to measure or quantify. Outside of a large, very expensive randomized controlled trial, which we'd love to do, but it would be inhibitively expensive. And also in the pro athlete arena, to do placebo-controlled trials is actually quite challenging. Because most of them, whether it's private, if it was a NHS-funded trial, you tend to find most pro athletes are in the private sector, not in the NHS. So you totally struggle to recruit them. So you end up with non-pro athletes. You tend to end up with surrogates like young medical students who play football a lot. And the pro athlete crowd wouldn't generally join a trial where they're not getting a treatment. They wouldn't agree to be in an arm of a treatment. We found this before with studies we've done where they refuse to be in a treatment where they're getting the placebo arm, or there's a 50% chance.
What's a placebo?
Placebo so in a trial we have in a controlled trial we have an intervention arm where you're actually getting, for instance, the simplest way of explaining it would be an immunization. So when we did the COVID trials recently, those have been controlled trials, so randomized controlled trials. So half the patients, if we inject 10,000 patients in a vaccine trial, half of them, 5,000 will get the vaccine. The other 5,000 will get a pretend.
Oh, right. Okay.
Pretend vaccine. So that's what the placebo is.
I see.
They don't know.
But everyone thinks that they've got the same
Everyone
thing.
thinks they've got the vaccine because it's in the same syringe. They all get an injection. It looks the same, feels the same, has the same volume. And the patient's usually blinded, so the patient doesn't know what they've had. The highest standard sometimes that we put this to is double-blinded. And what that means is that the person giving them the injection doesn't know either. And we do run trials where they're double-blinded, so the doctor or the clinician delivering the injection to the patient doesn't know what they're giving either. In some cases that's possible because the stuff looks the same and it's delivered in the same way. Obviously in certain cases, like some of our trials, it would be more challenging to do that because the substance looks a particular way. As long as you can see it, you won't be able to blind the clinician from what they've done. But there's a way around that because you can get the evaluation done by somebody who doesn't know what was given to the patient. You separate out the deliverer, the person doing the intervention, from the person who assesses the outcome.
I see.
And so that's another way of achieving independence and validity in a trial. The long and short of it is that we treated this athlete with what we thought was the best possible option to try and give him some marginal gains to a slightly quicker recovery, and his primary goal was, can I get back into training that bit sooner? And certainly when I spoke to one of our very senior pro physio providers who's now treating this athlete, he at the 4-week stage post-treatment was very impressed. He said, I can't believe that this chap had a grade 2+ collateral injury 4 or 5 weeks earlier because he's doing remarkably well. His laxity is already diminished. I can barely detect any when I examine him, and he's already back into inline work, and now a couple of weeks after that he's doing even more than that. So he's doing lateral loading, he's building up his proprioception in the knee already. So his training is accelerating really well. I could guarantee him a result, and that was quite clear when I treated him. And time will tell. Time will tell. If he wins his next fight, then I'd like to say that maybe 1% of that was us. but we'll see.
Be keeping your eye out.
Yeah.
In terms of his response to said treatment, is that like a genetic thing? Can it be genetic, or can it be like what are the factors here?
Yeah, really good question. I mean, people's genetics is super important. The problem is you don't know how important. And that's another massive area of medicine where there's huge potential, but huge risk. So we've got to the point where we can very cheaply and very quickly map an entire genome in a patient. So we can tell you all of your genes, all of your DNA sequences and chains, and we can map them all out, and then we can attempt to work out what things your body metabolism is optimized for. Whether you should eat this, drink that, whether you metabolize a particular substance better than someone else, for instance, carbohydrates or lactose or etc. So a huge amount of potential showing that at a cellular level and at a genetic level, your body is better suited to this type of exercise or this type of nutrition or this type of disease risk, etc., etc., etc. So huge promise, but again, huge under-delivery at the moment. We struggle to understand at the minutiae level each individual patient. I can't realistically put a patient in front of me and say, you need to do this, because if you do that, this is what's going to happen. We're not at the point where we can still say that. There's no guarantees in this. What we tend to say is there's a tendency with people with this DNA profile to do better if they eat carbohydrates. That doesn't mean that all of the patients that we say that to, it's truthful. That's the problem. So it may be true for 75% of them, but the other 25%, it probably makes no difference, and we don't know that, and they don't know that. So we're guessing. So we're still at the guessing stage. But your healing and your recovery, your tolerances, your exercise ability, your endurance, your stamina, your strength, your conditioning, all of that can be genetically influenced. So yes, there are people who, I say, we see. I'm a surgeon. I operate on people all the time, and I get those patients who come to me regularly and say, "I'm a good healer." And I think, okay, well, what makes you say that? And they say, well, when I had this injury or that injury, or I've had this operation, look at my scars, and that was like that 3 weeks. 3 weeks, 4 weeks, I was healed and I was doing really well. And then you obviously get those patients who are quite miserable and will say, oh, it takes me a long time to get over this, and their scar hurts, and they're very sensitive, and their wounds blows up in a particular way, and their scar looks very ugly for a year. So people heal in very different ways, and that is genetically driven. That is that's quite important. And we know there are risk factors; those are well established. For scarring and healing around genetics, background, ethnic background, skin types. But we can't predict it that well.
So things such as skin types, background, ethnicity, that can have an impact on how you heal, or is that?
Yeah, it can do. I mean, the commonest example is dark skin and keloid scarring, but that's a slightly different issue. But your ethnicity and there's no absolute rule, particularly in the pro athletes, because they tend to be in that sort of higher band of everything. Their muscle mass is better, their bone density is better. They tend to be special when they're in that professional banding, because they work so hard effectively, and they test their body to those extremes. Whereas the majority of us, we know, for instance, Afro-Caribbean origin people will have higher bone density. They tend to have thicker skin. That makes that gives them some advantages. It may sometimes give them some disadvantages, there are other ethnic and genetic differences in amongst our human species that are well established, been known for a long time, down to hair thickness, skin color, eye color, and the associations that creates with disease profiles, healing. Again, has been fairly well documented over the decades. So it's something that we know has an influence. It's just that we can't predict it from person to person. And that's where the difficulty is. We're getting better at it. So, watch this space, because genomic understanding is different to regenerative medicine. Regenerative medicine is... regenerative medicine is a promise of resolving disease. Is a promise of resolving disease. Whereas genomics is the understanding of influencing disease and and risk stratification, which I think is probably the earliest gain we'll probably get from genomics. Before we learn the real risk to manipulating the genome, which is a thing of sci-fi. Many films made about it, but we know we're rapidly heading into that space, which worries me slightly. It certainly worries me more than regenerative medicine and stem cells do. I can tell you that now. Genetic manipulation is something that worries me.
When you turn on certain genes, turn off certain genes.
It's absolutely, because the interaction of some of these genes and the interaction of some parts of the DNA molecule to other parts is unknown. So the risk of us causing what we call unintended consequences. We may be trying to do the very best thing we can for this person by turning off this particular gene that gives them a particular disease. But what we don't know is if we do that in every individual, what happens? Because they're not all the same. Obviously, all these people are different, and the connections, the connections between that particular gene and what it does in patients X will potentially be very different in patient Y, and that's sort of what worries me in that space. That, as you say, a little bit of a domino effect, that you change one domino and you don't really know what's going to happen to the others. You may knock one or two others out, and they make no difference to the patient, or you can create complete havoc in that genome, which changes fundamentally something in that patient.
Can it be a physical change? Can it be a psychological change? Maybe the person's...
Well, psychological. Well, the answer is you're probably genetically programmed in so many different ways, and that's where the sort of danger is, that it can influence almost anything. Right. So I don't want to be a doom monger. I think it's a huge area of medicine. There's no way people are going to not develop it. Because the potential is too enormous to ignore.
Is there like a certain amount of funding that goes into it currently?
Oh, huge. Again, it's one of those. I think probably genomic funding and understanding is one of the few exciting areas of medicine that outstrips regenerative medicine significantly. So there's a huge market in it, and all the companies are out there trying to develop specific gene therapies, gene programming, their understanding and enhancing this understanding of the genome. I think I've already mentioned the word Holy Grail. I don't think in of itself it's a Holy Grail, but the understanding and getting to a point where you really understand that turning this off does this. At an individual level, it would be immense. Would be immense. I just think we may never achieve that, or we're a long way from achieving that in a reliable fashion, but we're playing with it already. And that's a slight worry. And I don't want to scare people. I'm not part of Project Fear. But zombie apocalypses. Have you seen all those movies?
We're heading along there. We're heading around there.
I mean, I think hopefully we'll never see anything like that. But but you can see those films were based on genetic changes in humans. That's fundamentally what they're based on. Obviously, they're pretty scary, and I hope we'll never do anything like that to ourselves. But that's sort of the risk. Do we produce a disease? Man-made, essentially, from manipulation of genomes. That do we produce a disease, or do we produce a change that we can't, or an unintended consequence of, which we can't then reverse?
Something
or treat. So that's slight worry, and that's why science has to be responsible.
So I mean, talking in terms of you were saying how different people can have different responses to treatments. One question I had is, does the psychology of how you think about something affect it physically in terms of how it heals you? Say, for example, I've injured my knee. If I'm really down in the dumps about it and I've had PRP treatment, whatever treatment is required, if I'm super down in the dumps, will I recover differently to someone who's quite optimistic and quite positive about it? Is there a way to measure that?
That's a really good question. Whether the reality of that is, I can't tell you that we know that definitively. But what I can tell you is there's quite a lot of studies actually that show that psychology does have an impact on healing. But it's not simply a case of positive mental attitude. At the end of the day, if you've got a physical injury and you've got laxity or a broken bone, being positive about it doesn't make it heal necessarily any better. But what it may do is it may allow the individual to adapt or accept that injury and hence progress with it in a slightly different way. But what's probably more interesting from a regenerative medicine perspective is that what we know is that simple exercises like meditation and relaxing and reducing your cortisol levels in your body has been measured. So people who there are really good studies showing that adapting your stress levels by something as simple as 20 minutes of meditation a day actually increases your overall health and well-being, improves your psychological parameters, and thirdly has been measured. There's been measured biological response that your stem cell responses improve with meditation. So with stem cells, we what we can do is we can quantify the number of stem cells and their activity by the surface cell markers on particular stem cells. And there have been studies done on people, on groups of patients who meditate and those who don't. And they've shown that from the baseline, so where they started taking it before they started to meditate, 3 months later when they do blood tests or samples on those patients, they stem cell activity, and hence our extrapolation of that is that healing is improved. It's quite difficult necessarily to measure that they have healed better or their bodies are in a better condition. They may feel better, but that, as you say, could be psychological. But at biological level, we have measured differences. We have measured an improvement in health parameters, telomere length, and surface cell markers on stem cells have increased, showing increased activity and numbers of stem cells in patients who are meditating.
Right. Is there different types, different kinds, or has it just been like a blanket research done just on it generally?
No, so there's a few of these studies out there. So
what would be the most kind of the biggest one, so to speak?
So I think I'll have to pull the reference for you, but I've got them. I've got a massive folder.
We'll whack a link in the bio to some of these studies just so people can have a read.
Absolutely. So I'll pull those studies off because they were really interesting. When I read them, I thought, wow, this is something I didn't even know anything about. I just read it a few years ago. So I've saved a lot of them. I've got a folder on my Dropbox with thousands of studies in, which I can't read anymore because there's too many of them in there. So I can't go back to them. But whenever someone sends me something or I read something, I go, I'll save that. I'll save that. And I've now got hundreds and hundreds and hundreds of these papers sat in a folder that's not particularly well organised. It's just dumped in. And somebody asked me recently saying, can I get that folder? And I said, well, it won't make any sense. So what I actually need to do is go into it, skim and read those studies and put them into folders. This is for knee arthritis. This is for tendon arthritis. This is for psychological outcomes of meditation versus regenerative medicine and so on.
It's potentially one of the things you can feature on the Pinnacle Foundation, because I know we spoke about having a website for it, and we'll touch on it in a second, but that's potentially one of the uses for it, because it'd be a great source of information. Yeah,
absolutely. That's sort of the point. I think the foundation was partly up-to-date studies, but also just lots of data and resources and papers and research articles, and people can just pull down. Lots of stuff on there. So I wanted it to be a repository of information. That was sort of the plan for it. So we'll see. So that's a plan.
So, but in terms of now, another question I had was, and this is something that gets said to me a lot, especially training in different gyms, especially in MMA. One of the problems with combat sports nowadays is doping. People being tested for doping, etc. Now, with some of the stuff you're mentioning about stem cell therapy and how it can increase the amount of or reduce the amount of time it takes healing, does it have a similar effect on the body to steroids? Is it a steroid or is it something completely different?
It's completely different, because I think steroids have systemic effects. Stem cell therapy, by and large, when delivered in a targeted way into a particular area, doesn't really have a systemic effect. It has a local effect.
Could I have say I wanted to make my biceps bigger? Could I just pump them full of stem cells and just work out a lot? And would that increase the amount of mass I'd generate? Would the amount I'd grow similar to a steroid, or?
Possibly, but it'd be a very expensive way of doing it.
Yeah.
So there are much cheaper ways of getting muscle mass. Obviously, the simplest being just working harder.
Yeah.
But the answer is yes, potentially, and that's why we do require for the pro athletes, we actually require anti-doping agency approval before we treat them.
Yeah.
So we normally send them the treatment that we're proposing, and they have to approve it.
Okay.
So they actually have to approve it. So we fill out a form, and obviously there are different doping agencies. The UK one we're used to, and USADA, the US anti-doping agency. So we're sort of used to treating some US athletes, and so we're used to their system. So we now know what they approve, but obviously that can change year on year.
Yeah.
Which is why you do have to do it case by case.
Yeah.
So we will normally send them, and that's why, like I said, one of the reasons I really like Goldic is it's so clean. It's a patient's own plasma with concentrated proteins. It's got no additives at all in it at all. And it's got no cells. So we're not talking about stem cell responses or cells that are doing anything. It's a pro-healing, anti-inflammatory, immune modulatory serum. And so it is something that's of real interest to me at the moment, and we're doing more and more research and studies into this area. And I'm really looking forward to some of the outcomes of that. But I can't see why that as a substance, but also things like PRP generally are approved because they're autologous. They're from the patient. Yeah. They're just concentrations of growth factors and proteins and cells, and they're delivered back into the patient to improve healing in a local area. So they don't tend to have a systemic effect. They don't make you bigger, stronger, faster, generally. Which steroids can. Obviously, anabolics, etc., are systemic.
But it wouldn't be something that's like coming into the body per se. It's something you're taking from the body and then kind of localizing somewhere else.
Yeah, you're processing it. You're enhancing the important parts that you think will help with healing or reducing inflammation, and you're putting it back into that local area to try and enhance the signals of healing. To generate more normal tissue rather than scar tissue. So those are the kind of things you'll
get some silly people out there who'll be like, "Oh, you healed so fast, you must be doping." But really,
actually, I mean, to some extent, it's almost the opposite. If you're doping properly, you probably heal slower.
Really?
Yeah. So steroids over time, so the anabolics, etc. They can generate huge gains in muscle mass, etc. We all know that because of the metabolism effect they have. However, over time, they actually weaken your tissue.
Right.
So the long-term effects of steroids is weak tissue. So I see plenty of bodybuilders whose tendons rip off.
Wow.
When they're exercising, they can just be in the gym as they push a little bit too hard. And that tends to happen as they get a little bit older. So in their 20s, it's not something they notice. But I get plenty of mid-30s to mid-40s athletes.
Yeah.
Who are
wheelchairs, right?
Yeah, who are, I think the wheelchair, a lot of them is, I wouldn't say a lot of them, you occasionally get, and those tend to be the extreme end.
Ronnie Coleman, I think it happened to.
Yeah, it did happen to Ronnie, but he was at the very extreme end, obviously. He was, by reputation, possibly the best or, the king of bodybuilders ever.
Yeah.
So I think that's an exception. If you're the best in the world ever, you're probably in a slightly exceptional category. So Ronnie was certainly in that slightly exceptional category. And so he was pushing himself at a level that most people wouldn't even be able to push themselves to.
Yeah.
So I think when you're achieving at that sort of level, you can cause yourself harm.
Yeah.
And the body can really only take so much.
Mm.
And so over time, anabolics, etc., were generally, I mean, they weaken your tissue, and as I said, once you're in your 30s and 40s, that sort of comes back to haunt you, and certainly as you get a bit older, some of those effects are reversed over time. So if you stop using for a long period of time, you may go to sort of a baseline level, but actually some of the effects on that tissue is permanent. You actually find that 5 or 10 years later, you're still more prone to ripping or tearing something than had you not used them. Right. So the effects can be actually prolonged and long term. So it's something that I always speak to our athletes and say, you need to avoid this stuff. But the individual choice made by athletes for the pressures on them. He's not something I can control. I can just offer them the best advice, and the best advice is to avoid it.
So, I mean, does growth hormone kind of fall into that same category? I know a lot of people take it.
It does. I mean,
TRT, I think is another one.
TRT, yeah. I mean, there are growth hormones. There are analogs of growth hormones, and all of them effectively give you an increased ability to train and recover potentially, and that's sort of what people use it for. People think growth hormone makes you grow, and yes, it does. I suppose it sort of does, but it does it indirectly in the sense that you can recover quicker, you train harder, and you and then you've potentially got the molecules in place that will allow you to expand muscle that bit quicker.
Doesn't really have an impact on height, does it?
No, not when you're already fully grown. So you know, I mean, you unfortunately for males, generally at 16, 17, you're as tall as you're going to be, and for girls that tends to be at 14, 15.
Trying to give a bit of hope for them.
So you know, taking growth hormone in your 20s is not going to generally have a huge amount of positive benefit for you. Right. Certainly not in the height stakes. And obviously none of these things are doping agency approved. They'll get you into trouble, so avoid them. They're not good for your body generally. They're not good for your system. But you know, I can understand the pressures athletes are sometimes under to take these things, but they're not good for you.
Yeah. All right. Well, I mean, I think that answers some of the most common questions I've been asked. You know, when I was training with. Because the athlete we were mentioning, we were talking about his recovery stages. A lot of the times, athletes who tend to be exceptional are accused of things like doping. There's athletes I know who are suffering from, you know, injuries and stuff that have been prolonged over time. Treatments like this would help, but someone who doesn't understand what exactly they're given would accuse them of, you know, suspected doping, etc., etc. It's good, you know, that corporations like the UFC are aware of things like this, but I think it's important for the public to know exactly what is on offer here. Well, not so much on offer, but the medical world is moving to this kind of treatment, right?
Well, I think, there's definitely the medical world, particularly the private sector of the medical world, follows patient demand.
Yeah.
And patients are demanding these treatments because they're hearing potentially the promise, you could say. Some people would argue the false promise at this stage of regenerative medicine. I don't think it's a false promise. Yeah. I think it's an incorrectly marketed or delivered promise. Yeah. The promise is there, and I think it just has to be used responsibly. Yeah. People have to be honest with patients. Remember, that's not all we do. I mean, at Pinnacle, we're surgeons, we're sports medicine specialists. We've got sports med consultants that look after football, rugby, boxing, Olympic teams. And we offer a sort of holistic, wide approach. Where most of our team are surgeons, so we can operate on patients. We can do everything that other surgeons would want to do to patients, but we just have a slightly different philosophy in that we try and enhance our outcomes, both without surgery if we can get away with it, because surgery by and large, if you need surgery, you need surgery. Yeah. I'm not averse to saying to patients, no, you can't have that stem cell treatment or that PRP treatment or that plasma treatment that you've read about. Yeah. It's not suitable for you. I've had 2 consultations like this week already. Yeah. Where I've just said to them, we could do that for you, but I think your gains and risk benefit for you, financial risk as well, if somebody pays £1,000 for something that you think is probably going to give them limited relief and only for a short period of time, and what they're actually after is a long-term result, then you're being disingenuous. And I don't offer those patients that treatment. I say, what are you after? Yeah. I want my knee pain to go away. But what, for 3 months, 6 months? No, I want it to go away forever. Then you don't have this injection. Yeah. Because it isn't going to take it away forever. It's going to give you 6 months maybe because you've got advanced arthritis. You may get some relief for 3 months or 6 months or 12 months even, but then it's going to be back. Yeah. And then you're going to need an operation. And we may be able to delay that operation slightly. We may be able to make you more comfortable while you're waiting for an operation, but it's not going to stop you having the operation. Yeah. And in that case, they elect to either go to the NHS and have surgery, or they come to one of us and we do this operation privately, which is available. Yeah. But you know, I don't. Not everyone's suitable. for regenerative medicine. And certainly, actually, I'd probably argue that almost the majority of our patients aren't suitable, because we often see people at the late stage of disease. And that's the nature of medicine in this country. People don't tend to come early. They tend to come late. And that's probably a product of the National Health Service, actually.
You think so?
Yeah, so I think we've created barriers and expectations over many decades, and most patients know that, well, I only really want a knee replacement or a hip replacement or I have a problem dealt with when I've got to this certain stage of disease. And prevention's never, that's right. Prevention's never been an option, and the doctors have never been in the prevention game enormously. So it's a difficult place for those patients to come to a private clinic, expect a miracle with stem cells, or with a plasma treatment that they've heard of, that a friend down the road may have had a fantastic result of. I do get a lot of cross referrals from patients. So a patient spoken to somebody else at the golf club or one of their neighbours and said, I had this injection from Mr. Mahmood or the team at Pinnacle, and I've been great. And then their neighbour will turn up, but their disease is completely different. They're much more advanced sometimes. They're already on a waiting list for an operation, and I have to be honest with them. And like I said, I suspect probably about 50% of the patients I see, if not more, I actually say this is not suitable for you. You need to go for traditional surgery, or and if you need a stopgap for pain relief, then we can do something else. Occasionally we'll use steroid, although I'm not a fan of steroid. We know the relative harmful effects of steroid in the long term, but in somebody who's already got severely degraded knee joints, probably risk benefit is not really against them having a bit of steroid. But there are alternatives as well for temporary pain relief, but they're going to need surgery. So at some point. And so again, if you have that open, honest conversation that I've had, as I said already this week, I've sent 2 patients away. They've rang me subsequently and said, thank you for your honesty, and they're on one of them's on the NHS waiting list, and one of them is paying for a knee replacement. With a private surgeon that's not part of our group. They've gone to somebody else that a family member was operated on by, and I hope they have a great result. So that's it. I mean, I think all you can be is keep your integrity, be honest with your patients, maintain trust, and I think. Certainly myself, I think the NHS never leaves my system. I still work in the NHS at the front line, and that keeps you grounded.
Because a lot of people would just see it as a free payday, right?
Well, yeah. I mean, unfortunately, I know clinicians that I've met over the years who would do exactly that. They'd just say, "Well, let's try this." Without spending the extra 10 minutes explaining to the patient why it may not be the best option for them. Because at the end of the day, if your lifestyle is very private practice driven, or you're purely private practice, then
you need to profit as much as you can.
Well, yeah, your every hour becomes a dollar, a pound sign. So your time is money, and that's true. But I think I'm not saying this about all clinicians, so I don't want anybody sending me lots of abuse from the medical community. But I think people who are 100% in private practice, it makes me think sometimes about their incentives. And it's something that, but again, that's probably just me, because I'm very NHS orientated probably, and I'm a researcher, so it's something that probably impacts on my psychology more than it does others. I'm sure and I do know some fantastic clinicians that are full-time private that are very, very good and have maintained their ethics, but I know an awful lot that haven't.
So, I mean, essentially the goal of this podcast, even with the name, stopping the clock, it's interesting because initially I mentioned turning back the clock, and you said to me, no, you can't say that because we're not turning back the clock, we're somewhat stopping the clock. Because although it's called regenerative medicine, you're not regenerating an issue per se back to what it was before. You're stopping it getting any worse.
Well, yeah, I mean, that is probably more realistic way of looking at it. I mean, I think when I always say to patients that if you come here looking for the knee or the problem, your body when it was 20 years old and you're now 65, not going to happen. So this is the realistic expectations of the interventions that we've got available. You're going to get some pain relief, for instance, or you're going to get some improved function potentially, but you're not going to be 40 years younger. Your knee's not going to return to the way it was when you were in your 20s or 30s suddenly, or even not even suddenly at all. It's not going to happen over a year or 2 years. That's just not going to happen. Whereas what we can do is we've shown that we can reduce the progression of disease. And so the future of this space, as I see it, is we get people who come in earlier when their knee starts to niggle and starts to bother them. And in those people, I'm fairly confident that we'll be able to demonstrate over time. They're the people that we can leave without, as I mentioned earlier on in the podcast, that we put them in a place where they are living the best life they can, pain-free, improved function, for as long as possible. So rather than developing arthritis in their 40s or 50s, there may be people that develop arthritis in their 60s, 70s, so we can delay the onset of the inevitable. And my hope in 20 or 30 years, probably after I've retired, is that we'll be in a position where we can turn off osteoarthritis. I can see the future of this space being that we'll have blood tests and biomarkers or fluid samples we can take from people's knee, and we can show and measure, and we can already do this, but we'll be able to measure whether their biological cascade that starts arthritis has begun in the knee. And if it's begun, is it continuing or has it stopped? Because every injury that you get in a knee from a knock in football or a fall, etc., can generate that cascade. But in most people, it turns off. But there is a proportion of patients it doesn't. And if it doesn't turn off, what can you do about it? And I think hopefully before I retire, we'll be in a position where we can actually measure that fairly reliably. And we can give people a substance. Some of those substances we already have in our hands, where we can turn it off. We can turn off that biological, because arthritis is seen as a wear and tear disease, which implies it's a mechanical problem. What we know is that arthritis is a biological problem. Once it starts, it can start with a mechanical problem, but once it starts, it's that inflammation and the chemical signals that the joint then is subjected to that create that arthritis that now becomes progressive and degenerative and wears over time. So if you can turn off that biological signal, you may never get there, or you may slow it down and degrade that progression quite significantly. And I think that's the stage I'd really like to be at before I retire.
So, I mean, that's the goal of this podcast, is to inform people as well, just so they're more aware of what's happening in the space. Hopefully it transpires into something quite big. But we will have a section or an email or some form of contact where people can send in questions. But I think that's a good place to end it here. We've given it about a good hour, I think it's been.
Way too long.
Yeah, it's probably been a lot longer. But we got some really good content out of this. So thank you, everyone, for listening.